and gentlemen, Happy New Year. Welcome to 2023. If you don't know me, my name is Noah Greenspan, and tonight we are going to talk about some things related to ultimate pulmonary wellness, and we're going to talk about things from a different angle. Very often I try to talk about things that work. Things that work is the subject tonight, things that work. Tonight we're going to talk about things that don't necessarily work or things that are supposed to work that don't and why. So I want to start off by, just reiterating, the components of ultimate pulmonary wellness, which is that we talk a lot about the idea of the 5 pillars. We talk a lot about the idea of medical aspects of our care and well-being. We talk a lot about the fact that medical includes having the right doctors, having the right team, taking the right medications and taking them properly. We talk a lot about exercise, right? And exercise is crucial. And I would even make the case that I can, work with people and accomplish the exact same thing with exercise that we do with medications and or other treatments. As well. We talk a lot about nutrition as it relates to the cardiopulmonary system. And we talk a lot about stress and anxiety as it relates to the cardiopulmonary system, because we know that stress and anxiety, we know that not being able to breathe or shortness of breath is very stress and anxiety producing. And we know that stress and anxiety can make it more difficult for us to breathe. And then we talk a lot, especially in the last couple of years, about prevention of infection. And the things that we've been talking about lately, obviously, are COVID. And at some point, I could talk about what I learned from actually having COVID after avoiding COVID for 2.5 years in the fire. But I want to talk tonight about why some things work and why some things don't work, right? Because we've been talking about this long enough that we know that it's medical and exercise and nutrition and stress and anxiety and prevention of infection. But I want to ask you a question, and I want you to think about this. I'm going to ask you about each one of those things, and I want to know by a show of hands, how many people are 90% or more satisfied with the quality of their medical care, with their medication regimen, meaning the medications they're taking, and their efficacy, meaning how well they work, and their medication program. So how many people are 90% or more, 90 to 100% satisfied with their medical regime? Okay, so on screen 1, I see 1, 2, 3, 4, 5, about 7 people. Screen 2, I see about 1, 2, 3, 4. So not many people. How many people are dissatisfied or less than 90% satisfied? Raise your hand. All right, so a lot of people dissatisfied. So we're going to talk about why. We're going to talk about why and what it means when your doctor says that you are maximally medically managed, right? And that sometimes or often seems like it's not good enough, right? How many people here would say that they are 90 to 100% satisfied and feel 90 to 100% accomplished as it relates to their exercise program? Okay, so a handful on the first page. Let's see the second page. Handful on the second page. So how many people are dissatisfied? Raise your hands. All right, so a lot of people dissatisfied with their exercise program. How many people would give themselves a score of 90 to 100% as it relates to their nutritional status? As it relates to their nutritional status, what they should or what they think they should or shouldn't be eating? I see about five people on the first, no, a little more than 5 on the first page. How many people are dissatisfied with nutrition? Or who could be doing a little better job? All right, how many people feel stressed and anxious right now? All right. Many people on the second page. How many people on the first page? Raise your hand, stressed and anxious. All right, before we go on, everybody close your eyes for 1 second. Just take a nice deep breath in through your nose. Blow it out gently through your mouth. Nice deep breath in through your nose. Let it out gently through your mouth. Nice deep breath in through your nose. And let it out gently through your mouth. Open your eyes. Show of hands. How many people feel different after those 3 breaths? How many people feel better? How many people feel worse? All right, good. No one feels worse. That's good. Finally, how many people feel like they're doing everything humanly possible as it relates to prevention of infection? All right, not bad, not bad. All right, so now what we're going to do is I'm going to go back to each one of these things, and I want to talk about the shoulds, right? So we all know about the woulda, shoulda, couldas, and we all know that there are certain things that we think we should do as it relates to medicine and as it relates to exercise and nutrition and stress and anxiety management and prevention of infection. But there are times when even if we do everything right, we still don't get the results that we want. And we still don't get the results that were promised by the commercials, right? Because the commercials seem to make things look very, very good. But there are often times ways in which we can tweak the individual program so that we can get better results, because we know that not all things work for all people. Right? And we know that breathing, as I say over and over again, is multifactorial. And, you know, when something catches on in today's internet world, it goes viral and it's like, it has to be done this way. It has to be done ABC 1, 2, 3. And then everybody says ABC 1, 2, 3, ABC 1, 2, 3, ABC 1, 2, 3. But what if you say ABC 1, 2, 3? That doesn't work for me. Now what? Right? So how many people have been given instructions, and it could be about how you take your medicine. It could be how you use your aerobica or your a cappella, how you best clear your lungs, how you do your exercise, and it just doesn't work. Or how many people have been given instructions on how to lose weight or how to gain weight, and it just doesn't work. Or how many people have been given instructions about what works and what doesn't work in terms of preventing COVID, right? So my goal tonight is not to bark at you for 2 hours. My goal is really to speak for an hour and then answer questions for a half hour. But I want to talk about some of the things that are commonly held beliefs. And then I want to talk, this is not myths and this is not myths and misconceptions. Okay, this is different. That's a whole different talk. I will give you one important myth. But then I want to not talk about myths and misconceptions, meaning not what you're doing wrong, but some ways that we can tweak your protocols so that you can maximize them. So let me tell you about one tweak or one myth that I hear people saying over and over and over again. Even the top guns, even people who are like the director of the program are giving you this misinformation. How many people have been instructed when it comes to breathing to breathe in as if you're smelling the flowers? Raise your hand. Not too many. All right, how many people have been told to breathe in through their nose? How many people have been told to smell the flowers and blow out the candles? All right, so let me say this. Blowing out the candles. Let's talk about that for a second. If you think about it, when you go to your pulmonologist's office, okay, what is one of the things that you're asked to do when you have spirometry or you have a pulmonary function test? You're asked to blow out as hard and as fast as possible, sort of like blowing out the candles, right? Does this ring a bell to anybody? Okay, so think about that. Does anybody know why you're asked to blow out as hard and as fast as you can? Raise your hand. Star Snyder does. Susanna Hunter might. Let's see who else. Lynn does. Dawn does. All right, so maybe 10 people do. But I'll tell you, just to streamline things, okay? I don't know if the Australians do, but the male Australian's hair has gotten very, very long, I noticed, since the last time I've seen him. He looks like he came from the outback just immediately. So here's the thing. The reason why you're asked to blow out as hard and as fast as possible is because blowing out as hard and as fast as possible is going to actually elicit the obstruction, okay? So if you have obstructive disease, and when we talk about obstructive diseases, we're talking about conditions in which exhalation is the problem, right? So people who have no difficulty breathing air in, but people who have a difficult time blowing air out, that's called obstructive disease. And the harder and faster you blow out, the more obstructed you become. So it's actually diagnostic, and it's designed to elicit the obstruction. So when you're breathing in through your nose, I have no problem with smelling the flowers, but you should not be blowing out the candles, because that is actually going to make you more obstructed, okay? And there's a concept called dynamic hyperinflation, and that may sound complex, but you may identify with the sensation more so than the title of it. And what dynamic hyperinflation means is that when you are exercising, or when the demand of your breath increases, as in walking up a hill, walking up a flight of stairs, running for the bus, okay, the demand is increased. And many people, although they're fine when they're at rest, once that demand increases, they can become more and more obstructed, getting more and more air trapping. And so think about it like a roach motel where the roaches go in, but they don't get out. So you take a breath in, but less air can come out. Then you take another breath in, and even less air can come out. And you take another breath in, and even less air comes out. And what that means is that your lungs become more and more hyperinflated, and you become more and more short of breath. So one of the paradoxes of shortness of breath, and one of the paradoxes of the breathing exercises that we teach you over and over again, is that the harder you work to breathe, the harder it's actually going to become to breathe. And when you get short of breath, okay, typically when people get short of breath, it happens at high levels of activity. So things like stair climbing, walking uphill. And when you get short of breath, all of a sudden you start to get anxious, because you're like, hey, I don't know what's going on here. It's like if you don't know how to swim and we put you into the deep end, you are not going to go in the deep end, right? So the idea is that you get short of breath. Shortness of breath makes you anxious. Anxiety makes you breathe harder and faster, and you become more and more short of breath. So the goal is always going to be to break into that cycle somehow. And the way that we break into that cycle is, number one, stopping whatever it is that we're doing, okay? So a car spinning out of control is not going to regain control by speeding up, right? So if you feel like you're losing control of your breath, or you feel like you've lost control of your breath and things are spiraling out of control, first thing you do is stop whatever it is you're doing. So if you're walking up a hill, stop. If you're walking up a flight of stairs, stop. Talk to yourself. Say, stop, I know what to do here, because you do know what to do here, right? I'm sure if I asked people here, what are you supposed to do? Number one, slow the breathing down, okay? And one thing that I've talked about over and over again, and that's in the book, Ultimate Pulmonary Wellness, is positions for recovery from shortness of breath, or recovery from shortness of breath. So recovery from shortness of breath is different than what we do, let's say, when we're walking at a leisurely pace, or when we have control of our breath. Recovery from shortness of breath happens, or is supposed to happen, when you feel like, hey, things are mounting. This situation is getting more and more dire. So first and foremost, stop whatever it is that you're doing. There are certain positions that are going to be helpful for you, and this is one of them, okay? So what I'm doing is I'm leaning over on my desk on my hands. I'm fixing my upper body, my upper extremities. This is another one. I'm leaning down on my elbows, okay? If I don't have any place to lean on, I can put my hands on my knees like this. If I'm sitting in a chair, I can lean over like this by putting my elbows on my knees. And what leaning over does, first of all, is it drops your abdominal contents forward. And when you drop your abdominal contents forward, what that does is it clears the way for the diaphragm to contract more efficiently, okay? So that's first and foremost. So stop, assume the position, find a comfortable breathing pattern, and blow out. Focus on the exhalation. Now, when we talk about restrictive lung disease, things like pulmonary fibrosis and other interstitial lung diseases, we're talking about diseases and conditions in which there is difficulty with inhalation, right? So people say, well, that doesn't make sense. I have trouble inhaling or I have trouble exhaling, okay? But it's like yin and yang, or it's like an elevator that has up and down. If it only goes to the top floor, you can only make one trip. And if it only goes to the basement, you can only make one trip if it doesn't go in the other direction. So what I'm saying is that people with obstructive disease and restrictive disease always want to call attention to the differences between them and the fact that pulmonary fibrosis is not COPD. And that's very correct. But I will tell you that the majority of things that work for COPD and obstructive diseases also work for restrictive diseases and also work for cardiovascular diseases or cardiopulmonary diseases like pulmonary hypertension, okay? I treat a lot of different cardiovascular conditions, respiratory conditions, mixed conditions, so people with cardiopulmonary or complex medical conditions. And the basic principles that we follow are the same. So in other words, the initial structure is going to be the same. The building blocks are the same, but we have a lot of different ways that we can tweak those building blocks and individualize them that can make them more effective for you. So there's a question in the chat that says, will the leaning also assist in reducing the cough? And the answer to that question is a definite maybe, okay? And the reason why I say a definite maybe is because it really depends why people cough. So that's a great question, okay? How many people here have a cough that is troubling to them? Raise your hand. Okay. How many people have a dry cough? How many people have a wet cough? Okay. So when somebody has a problem with coughing, okay, my first questions are always this. So I'm evaluating a patient, and the first thing I'll say is, are you having difficulty with coughing, or are you coughing, or do you have a cough, right? If the answer is no, I don't cough, great. Okay. No, I don't have a problem with coughing. Great. If the answer is yes, then I want to know, is the cough dry or are you bringing up mucus? So typically people with interstitial lung disease or pulmonary fibrosis will have more of a dry cough. It doesn't mean that people with obstructive disease can't have a dry cough, but typically people with restrictive diseases and ILDs or pulmonary fibrosis will have more of a dry, hacking cough. People with obstructive diseases, particularly chronic bronchitis, okay, COPD, chronic bronchitis, bronchiectasis, NTM, MAI, MAC, things of the nature, will have more of a wet or what we call a productive cough, okay? And I'll talk about each one and things that you can do for each one. Now, if somebody does have a productive cough, meaning that they are able to bring up mucus, I want to know certain things about the mucus. So it's almost like a flow chart. So it's like, are you coughing? No. Okay. Go over there. Yes. If you're coughing, are you bringing up mucus? No. And then if the answer is no, I'm not bringing up mucus, that leads us to another question. And that next question is it that that you don't have mucus, meaning that you have a true dry cough? Or is it that you have the mucus and for whatever reason, you just can't clear it? And I will say this, I recently had COVID, and it's been like 2 years and almost 3 years that I've had tons of exposures. I've seen tons of COVID patients, and I was so careful. And I had one slip up. It wasn't my slip up. It was someone else. Someone else roofied me essentially with COVID. That's what wound up happening. But I did learn something. Okay. And what I learned was that what I had perceived in most people to be a dry cough for these 2.5 years was not always a dry cough, but that it was such a compact cough, and that the mucus was so compact and impacted that you had to really just work and do a lot of different things to break it up and clear it. And even things that I've heard listening with a stethoscope, in which I hear, oh, it sounds dry, listening to myself, sounds dry. But if I work it with a nebulizer, if I work it with a bronchodilator, if I work it with a steroid, if I work it with my acapella or my aerobica, which trust me, I was doing all of these things when I had COVID, then I can actually break that mucus up and I can clear the mucus. So that was very interesting to me. Not that I'm glad I had COVID. Thankfully, I had a pretty mild case and I have no post-COVID symptoms, but it was worth it in the sense that I learned and it shifted my thought, not a lot, just opened my eyes. It reinforced many things that I believed for all these years. And it shifted my view a little bit on particularly the cough. So next thing is when we ask about the mucus, it's, are you able to bring up mucus? Is it thick or thin? Because we know that thicker mucus is more of a problem than thinner mucus, right? Because thick mucus is hard to clear. Thick mucus can affect your oxygenation more. Thick mucus often is going to make you more short of breath. Thick mucus is going to make you more prone to infection than thin mucus, right? And so our goals are always going to be moving to the direction from thick to thin. And then we ask about the color. And I say, is it clear, white, or colored? And if they say it's colored, I say, what color is it? Because we know that yellow and green point to infection. Although there are people with certain conditions like bronchiectasis, like NTM, where that is not an atypical color, even when you don't have an acute infection or even when your acute infection is mild, right? So that's the cough, okay? Here's a comment in the chat that says, my wet cough was identified as an ENT as due to overproduction of mucus post-nasal drip. Had the NeuroMark procedure done and changed my life. Okay, so I'm not familiar with the NeuroMark procedure, but what I will say is that a post-nasal drip is a lot different, okay? And the thing is, a post-nasal drip is coming down from above, as opposed to mucus that's in our chest that's coming up from below, okay? And also as opposed to reflux or GERD, which is something that always should be considered when somebody has a cough, especially during sleep or when they're lying down, and especially when they have respiratory disease, because we know that the esophagus and the trachea are very close together. And if acid comes up, acid is supposed to go one way, right? It's supposed to go down your, food is supposed to go from your esophagus into your stomach, and that acid is supposed to go further down the gastrointestinal tract. When it comes up, that's when we have this discomfort. That's when we have this burning. That's when we have this pain. And if that mucus or food stuff comes up and goes into the trachea and the airways, which is known as aspiration, that can significantly increase inflammation in the airways, making any respiratory condition that you have worse, okay? So cough is really important. And I want to talk a little bit about cough, and I want to talk about, let's say, secretion clearance. And I'm going to go a little bit out of order, but I'm going to go in whatever order it comes, and I'm going to really make an effort to stop at 8 p.m. and take questions. But let's start with the cough. Here's a question. I have thick mucus in the morning when I get up, and I usually cough a lot throughout the day. It gets cloudy or clear with lots of bubbles. Okay, so why do we have the most mucus in the morning? Okay, typically we're going to have the most mucus in the morning because we've been draining all night, right? So if you think about it like a ketchup bottle, okay, if the ketchup bottle, and I don't have a ketchup bottle, but I'll use this as an example, okay? So this is the top, and let's say we are coughing. We have a problem with cough. Now, if you put your hand in this part above your sternum and you slide it down sideways, you should feel a little ridge here, okay? Or a little, what's called the sternal angle or the angle of Louis. And the significance of the angle of Louis is that that is where the trachea splits into right and left main stem bronchi. And the significance of right and left main stem bronchi, okay, which then split into right upper, middle, and lower lobe, okay, and then left upper and lower lobe. The significance of this, now listen to this, because this is going to be really important. And if you have a problem with secretions and mucus and cough, then you really need to internalize what I'm about to say, which is that the cough mechanism is only effective in the large airways. The cough mechanism is only effective in the large airways, meaning that the cough mechanism is really only effective once you get that mucus up to here, okay? Which means that you can have mucus all down here, and you can have mucus all down here, and you can cough till the cows come home, and you will not necessarily be able to clear that mucus, right? So imagine again this ketchup bottle, and imagine I'm shaking and I'm shaking and I'm shaking, but I never turn that ketchup bottle over, right? Then I'm never going to get any ketchup for my French fries, right? But think about it. If we lay the ketchup bottle on our side, what's going to happen? The ketchup is slowly going to start dripping down and dripping down and dripping down, right? And if we tap on that ketchup bottle, right, you know, you're supposed to tap on the 57, right? Well, guess what? Then more of that ketchup shakes off the tree. And guess what? Then you're ready to shake it out, okay? And that's the exact same thing that we need to be doing if we want to really clear our airways. And clearing our airways is so important in terms of, number one, how well or how poorly we breathe, in terms of how well or how poorly we oxygenate, and also in terms of prevention of infection, right? So think about it like this. If you spill some milk, okay, I'll tell you right now, there's no use crying over it, but if you spill some milk and it goes under your refrigerator and you leave it there for a few weeks, right? What's going to happen to it? It's going to get harder and thicker, and it's going to spoil, and eventually it's going to have bacteria, and eventually it may have some viruses. And that's exactly what happens if you have mucus that you're not clearing very well. And that's why people who have respiratory conditions get infections very, very easily, or that's why these things settle in the chest. So in light of, I wasn't planning to start with this, but in light of cold, flu, RSV, COVID season, this is actually a great place to start. And my message, if I'm going to summarize, is that if you have a problem with secretions, and even if you don't, because we all produce mucus, right? We all produce mucus. It's just that some of us are more aware of it than others, for the simple, not that they're just aware. It's not like I have a higher awareness of my mucus than you. I'm better at observing my mucus than you. It's that there are, let's say, if you have normal, healthy lungs, we have what's called the mucociliary transport system, and that's working all the time, right? It's like this conveyor belt. It's the mucus comes up and the cilia move it up, and sometimes we expectorate it as we speak. Sometimes we cough it up. Sometimes we sneeze it out. Sometimes we swallow it. Sometimes it comes out in vapor, right? But we have a situation in which the body is prepared to help us clear mucus on a regular basis. Now, when you have chronic bronchitis, the definition of chronic bronchitis is a chronic productive cough, meaning productive, meaning that you have the mucus that's present for 3 or more months of the year for 2 or more years in a row, okay? When we talk about emphysema, emphysema is often associated with more of a dry cough, but we know that the majority of people with COPD often will have a combination of chronic bronchitis, which is disease of the larger airways and the bronchi, and emphysema, which is disease of the small airways and the alveoli. So I don't like to split hairs. You know, I think as human beings, we have so much in common all around the world. You know, I learned that in Disney World. It's a small world. It's like there's so much that we share that it's time we're aware that we have so much more in common that we have different from each other, and everybody wants to focus on the differences, right? The cardiac patients don't want to be with the pulmonary patients. The pulmonary patients don't want to be with the cardiac patients. The COPD patients don't want to be with the pulmonary fibrosis patients. The pulmonary fibrosis patients don't want to be with COPD patients. The cystic fibrosis patients don't want to be with anybody, rightfully so. But you get the idea. And again, my point in telling you this is that we have more things in common than we have separate, and more things work for people with cardiopulmonary disease that are common than are different. And I'm telling you right now that if you have any type of respiratory condition, it is worth your while to be focusing on some secretion clearance every day, even if you don't consider it a big problem, okay? How many people here utilize a secretion clearance device, something like the Aerobica or the Acapella or the Flutter Valve or the Vest? Okay, can anyone, show of one hand or two hands, how many minutes do you spend each day utilizing your secretion clearance device? 10? How many people? Okay, how many people spend 5 minutes a day? 5 or less minutes a day? How many people do 10 or less minutes a day? How many people do 20 plus minutes a day? Okay, Brian. Brian's a respiratory therapist, and he's also knows a lot about this stuff. He knows all about these machines. But let me tell you this. A lot of times you will get instructions that say, do this 3 sets of 10, right? How many people have gotten instructions like that? I want you to do your aerobica. I want you to do 3 sets of 10 in the morning. I want you to do 3 sets of 10 in the evening, right? Does it sound familiar to anybody? But how many people have done all their sets but still feel like they have mucus? How many people have taken all their meds but still feel short of breath? How many people have done their nebulizer but still feel short of breath or still feel like they have mucus? So what I'm trying to tell you is that it's not an exact science, number one, and that a lot of these things are nuanced, and that, you know, just because you read it in a book, even if it's my book, just because it was told to you by a respiratory therapist or a physical therapist or a nurse or a doctor, doesn't mean that it's going to work exactly that way for you. Okay. And what I'm trying to say, again, is that there are nuances to this, and there are tweaks that we can make. And there are ways that we can adjust your program for you so that you get maximum results. I'm going to just go to the chat for 1 second. Is that why CF patients get tapped? Yes, that is why we do chest therapy on CF patients. That is why we do chest therapy on bronchiectasis patients, NTM patients, MAC patients, pneumonia, anybody who has difficulty with secretions. Lily said, I can say no, I had none as lost smell, taste, cough, RSV, October 2022. Long COVID, March 2020, no smell, taste. When caught RSV, I had no symptoms. Okay, doctor was questioning, you had to explain the loss of smell and taste. Okay, I know your history, Lily. I know you've had a lot of struggles. I don't know if you ever went to the doctor that I arranged to see you, but we can talk about that. I know I owe you a phone call, and I will give that to you. Are the devices more effective than Marion's mucus clearance exercises? And again, the answer to that is a definite maybe, okay? Because the answer is they're going to be more effective for some people, and they're going to be less effective for other people, okay? And I always say that if Thor gets into a fight, what do you think, what weapon do you think he's going to use? It's hammer, right? Because Thor only has a hammer. And the thing is that the less experience you have with something, the less tools you have in your arsenal. But the more tools you have in your arsenal, the more you can experiment with them, right? It's like if you're a chef and you only know how to use 3 ingredients versus the chef who has, you know, you can give somebody who's not, you know, who's a novice chef 50 ingredients, and the more ingredients they have, it doesn't mean that they're going to make a better food, right? It doesn't mean they're going to make a better dish. But the point is that you can experiment, and there are certain principles like getting yourself in the right position, and the right position for secretion clearance has to do with putting yourself in a position where gravity is naturally going to pull the mucus up to the larger airways where you can cough it out. Does that make sense? That's why after you've been sleeping all night, or that's why you have this thick mucus, because you've just spent 6 or 7 or 8 hours draining, okay? That's why some people, when they first lay down, start to cough, because the mucus comes down to the large airways. And what I'm trying to say to you also is that how many people have been given the instruction like, hey, you cough when you lie down, so don't lie flat, sleep with a wedge, right? And yeah, that may stop your coughing, okay? But the problem with that is that it never allows you to clear secretions. So for that individual, my advice would be to make sure that you clear your secretions before you lie down, in the same way that I would say to somebody who's about to exercise or who's about to go outside that they should take their bronchodilators and they should take their rescue medications before they go outside. I'm going to stop there at cough and mucus, but I will say this. We have a lot of material on our website about cough, and secretion clearance and mucus clearance and so on and so forth. And it's done by the top guns in the game, the people that wrote the books, Donna Fraunfelter, Marion Mackless, people who I say the Viagra of secretion clearance, meaning if they cannot help you get it up, the mucus is not coming up. All right, this is time for the Puritans to leave the show. It's about to turn rated R. No, I'm kidding. It's not. That's my only joke. But the idea is that, you know, when you have one way of doing it, or if you're taught a certain, you know, technique and the technique doesn't work, then we can always add things to it or tweak it or try different things. Just as an example, I'm going to transition into medications, right? So there's benefit to doing secretion clearance before your medications. How many people agree? True or false? There's benefit to doing secretion clearance before your medications. How many people are on that side? Okay. How many people believe that there's benefit to doing your medications before your secretion clearance? Nobody? Nobody? I do. Okay. But you see, the thing is, it's not necessarily one or the other, right? So if you understand the principles are, if I get up and I am all the way locked up, right? How many people get out of bed first thing in the morning? Their lungs feel tight. They feel short of breath. They need some time to get warmed up. They need to take their medications. They need to get some lubrication going before they can get moving, right? Sounds familiar, okay? But the thing that I want to explain to you is that if you're locked up and you're full of secretions, okay, then that is not going to make it easy for you to get your medication, right? Think about it. It's like that mucus in your lungs, that locked up, or that inflammation in your lungs, or that spasm in your airways, or that constriction in your airways. Think of that as a traffic jam, right? And the thing is, if you're driving and the whole lane ahead of you is full of cars, well, you're not going to be able to go until they clear those cars ahead of you. And so in a situation like this, it may be worth your while to start using your device for a few minutes before you actually take your medication, so that when you take your medications, you actually get more of a benefit because you've just cleared the road, right? You've cleared the road a little bit before, and that's going to allow better delivery and better flow of the cars as you clear the crash site, right? Now, some people will say, yeah, but I can't clear the secretions until I take my medication. Then guess what? There's merit to that as well. And, you know, like many things in medicine, okay, or like many things in life, I mean, I could say you could make the argument for doing one way or the other. It's like why do we say, you know, tastes great, less filling, chicken, egg, right? So the idea is, like, we all want to take one side, right? We want to say, do we want this? Do we want that? Should you take your medication first? Should you do your secretion clearance first? And I'm going to say we don't know, right? We don't necessarily know. And there's not going to be one way that's going to be exactly the same for everybody. And there's not going to be one way that may not be the same for you each and every time. Now, you may find that you really get it down pat, and the more that you do this, you learn more and more about what really clears you. But let me give you an example, okay? I have a patient who's got a lot of secretions in all of his lobes, okay? So what that means is that if you have a lot of secretions in all of your lobes, okay, so we know that the right lung has 3 lobes, upper, middle, and lower. The left lobe has 2 lobes, the upper and the lower, and it also has the lingula. And then each lobe is divided into segments, right? And these segments can also have mucus in them. And then they divide, you know, into smaller and smaller bronchi and bronchioles. And then we get to the alveoli, which is the gas exchanging sacs where gas exchange occurs, okay? And you can have mucus at any point along this tree. And so the idea is that if you have mucus in many lobes, like if your doctor says to you, hey, you know what? You have aspiration pneumonia in your right middle lobe, and that's been visualized, and that's very clear that you have one lobe or one segment where it is, well, then you just have to do the segment and you have to be in the position for the right middle lobe. But if you're somebody who's got moderate to severe disease. And I'm not using those terms forcefully or with any like extreme, prejudice. It could be somebody who's got mild disease, okay? But if you have mucus in multiple areas of your lung, then you have to do multiple positions, okay? And so with my client, what I do is I want him to take his nebulizer before I get there. Okay, so let me start with that, okay? Because I usually don't see him first thing in the morning. So before I see him, I want him to take his nebulizer, okay? Now, when we talk about medications, we talk about medications a lot. We've been talking about it for years. We've been talking about how they're confusing, okay? But when we talk about medications for respiratory diseases and we talk about the inhalers, there's 3 basic types. 2 of the types are bronchodilators. 1 of the type is anti-inflammatory. So we have anticholinergic, which is a bronchodilator. We have beta-2 agonist, which is a bronchodilator. And then we have corticosteroids. So A, anticholinergic, B, beta-2 agonist, C, corticosteroid. And it took me probably 20 years before this hit me. And I always was trying to think of what's an easy way we can explain it. And then it just hit me. And I was like, it's so simple. It's A, B, C. And then Trilogy stole my idea. They're like, Trilogy, A, B, C. They stole the idea ABC, but they're not talking about the fact that it contains an anticholinergic, bronchodilator, corticosteroid. So it's like the people are telling a joke, but they don't really get their own joke. But the idea is that before we do our secretion clearance, we will get benefit from bronchodilation, right? Meaning we will get benefit from opening up the airways. And what that means is think about it as a traffic jam. So imagine if, guess what, we have this 2-lane highway or the traffic has been reduced from 4 lanes to 2 lanes, and now we have a car blocking one of the lanes, which is the mucus. Well, guess what? It's going to be a lot harder for air to move down 1 lane and around that mucus than it is 4. So the bronchodilator now opens us back up to 4 lanes, right? The other thing that it does is when you do it by nebulizer, and given the choice, I would prefer a nebulizer before secretion clearance because it's wetting, right? It's going to bring moisture into the airways. It's going to bring moisture into the lungs. It's going to bring moisture and start to help you break up and thin out some of those secretions, right? So that's going to make it perfect for you to do your secretion clearance techniques afterwards. And that means assuming the various positions, okay? So just as an example, I'm not going to go through these all, we've done them before, but lying on your left side is going to make it most effective for draining your right lung, okay? Lying on your right side is going to make it most effective for draining your left lung. Lying flat or lying in what we call semi-Fowler's or a 45-degree position, okay, is going to make it easiest for us to drain our upper airways and our upper lobes, okay? But if your mucus is in the lower lobes and you are upright, it's going to make it very difficult for you to clear that secretions from the lower lobes because we have to get it up to the upper airways where we can clear. And that's my only problem with the vest. I love the vest, except for one thing, which is that the majority of people who are taught the vest in upright, okay? And while it will shake the stuffing out of you, as Father Mulcahy from MASH once said, okay, it's not going to help bring things up as effectively as if you were in one of the drainage positions. So I encourage you to do these things, whether it's the vest or the acapella or the aerobica or any other type of PEP, positive expiratory pressure device, in various positions. So right side lying, left side lying, supine, 45-degree angle, okay? Now listen to this, corticosteroid, okay, anti-inflammatory. So many people, and when we talk about optimum management, okay, we're talking about you'll get 1 from column A, the anticholinergic, we'll get 1 from column B, the beta-2 agonist, and we'll get 1 from column C. But listen to this, the corticosteroid, okay? And this is why when we talk about the order in which you take your medications, the order is so crucial because the corticosteroid, I could have this right here. I could have a whole tube of Qvar or budesonide or Flovent or whatever it is, and could take the whole thing and nothing is going to change right now because corticosteroids or anti-inflammatories work over time to reduce inflammation, okay? Which means that if you get up and you're locked up, don't take your corticosteroid first, because that locked up is almost like a missile shield, right? The corticosteroid is going to go in, that mucus is going to come up and say, you're not making it in. Take your bronchodilator, open the airways. Take your nebulizer, open the airways, okay? Then do your secretion clearance. After your secretion clearance, when everything is wide open, take your corticosteroid. I can't tell you how many people, and nobody talks about this. I only know 2 people who talk about this. I'm one of them. The other is Mark Mangus, okay? Other than that, I've never heard anybody else talk about it, okay? And then I've heard people say, my doctor said the order doesn't matter. I've heard people say, oh, I should do this and that, or I take my, my anticholinergic in the morning, my Spiriva in the morning, and I take my, Ceravent in the evening. No. The best way to take your medications is to take your anticholinergic and your beta-2 agonist, your 2 bronchodilators in close proximity to each other. Let them start to work. Clear your airways. Take your corticosteroid, take your anti-inflammatory. Does this make sense? And understand that what I'm saying to you is a guideline, okay? It's where I start. But then there are going to be some people who we have to make changes. So this one client, sometimes I can't get him fully clear, okay? I can't get him fully clear on one nebulizer, right? So I'll get him as clear as I can. And if he's still wheezing, or if I know he still has mucus, but it's tight, I'll say, go do another nebulizer. And so we now get more bronchodilation, except this bronchodilation is going to be more deep. And more, it's like a deep clean, right? Because we've already cleared all this surface stuff. Now that next nebulizer is going to open you up even deeper, and then we can clear the rest of the airways and get the rest of the mucus out. I'm putting food on the table for you to think about. I'm not giving you exact recipes, okay? But I'm saying these are possibilities that you can think about. And I'm trying to say that if something's not working for you, at least ask the question why. At least ask the question why, and ask your doctor, ask your respiratory therapist, ask your physical therapist, ask your nurse. Don't ask Facebook, don't ask Dr. Google, don't put it on Instagram, don't do a meme, okay? But ask, is there anything I could be doing differently? And when you ask somebody a question, ask them, how much of this have they done, right? Like, how much experience do you have with chest therapy? Because not everybody is equal, okay? Not everybody is equal. We all know that not everybody has the same experience. We can graduate from the exact same school. You may go the path of administration, right? You may get an early promotion, become an administrator, become an educator. You may teach, but you may teach having never done the actual skill. Do you want to learn it from that person, or do you want to learn it from the person who's done it 5 trillion times? Okay, so I'll tell you a story. One time I was on a dive boat. We were looking for great white sharks, okay? There was a college professor there who was an oceanographer, but he had never dove with great white sharks. On the way out, he was trying to teach everybody about the behavior of great white sharks and what to do if we come in contact with any great white sharks, okay? Now, I have friends in South Africa who didn't even go to college, but they've been on the ocean with great white sharks their entire lives, okay? Now, this guy from Cleveland, Ohio, okay, got in the water with the great white sharks, and he panicked. And the only reason he didn't get bit by a great white shark was because my friend from South Africa, who's been with the great white sharks all day, every day for his whole life, got in between. So, like, this is the age of what I call the amateur expert, right? Or the expert amateur, or the expert novice. And I see people who take one class and then somehow they're teaching the course. So I encourage you, I could tell you that there are people out there that know every aspect of what we're talking about. Find the right people. And if somebody hasn't done it, then the only thing they're doing is parroting or repeating what they read in a book or what someone else has told them, right? And there's a concept that says, I'm not interested in simplicity on this side of complexity. I'm interested in simplicity on the other side of complexity. And what that means is that I can tell you something and you can watch my lecture, and yes, you can repeat it back to somebody, but you're not going to know these nuances, right? But it's the people who have been through the ringer, that have gone through this storm and come out on the other side to the sunny day and the simplicity. Those are the people I want to learn from. So don't be afraid to ask your clinician, how many times have you seen this, right? Because we know that particularly when it comes to interstitial lung disease, and we know particularly when it comes to COVID and when it comes to long COVID, it's rare, okay? Or it's not rare, it's either rare and or new, and less people have experience with that than they do with asthma or they do with COPD. So don't be afraid to ask, I hear what you're telling me, but can you show me? Can you do it with me? Can we try different things? Make sure you get to the right people. And if you have trouble finding the right people, let me know and I can introduce you to some of the right people. But that's medications, okay? I'm trying to tell you to use your medications to maximize your care. So again, when I see somebody who's walking around with their Flovent or their QVAR, which is their corticosteroid, I know that nobody ever explained to them how their medications work, because there would be no reason to have that out and about with them, okay? We've done a number of webinars on medications, okay? I encourage you to look at them, and there's plenty of writing about this on our website and in my books about proper medication use, okay? But the idea is that there's a better way to do it. There's a less effective way to do it. And the most effective way may be the least effective way for somebody else. But some of these things are more important to be set in stone. Like what's set in stone? I would say what's set in stone is that if you take long-acting bronchodilators, okay, like let's say as an example, a Neuroellipta, or let's say you take a any long-acting medication that you're supposed to take twice a day. What I would say is important about it is take them 12 hours apart. That's important, okay, to establish your bookends. What you do in between, I'd say there's more flexibility to, okay? And the key is to try different things and to try to find what is most effective for you if what you're doing is not working. Now, if you say to me, hey, you know what? As soon as I take my medications, I'm good to go. I don't get short of breath for the rest of the day, or I don't get short of breath till the next time I'm supposed to, get my medication, then no problem. Then what you're doing is working for you. But I know from seeing a lot of people that people are often following programs, and the programs are not always the most effective, and they don't always know exactly why, or sometimes even vaguely why they're doing things in a certain way. So I encourage you to ask questions to understand the principles. My book is available for free on our website, pulmonarywellness.org. So anything I'm talking about now, you can get from the book. And I will share with you that I am working on a new project, which is going to be an interactive online course that has everything searchable. So any word you think of, you put in the search bar, and you're going to see anything and everything I've said about it within the past 30 years. Now, I'm not saying that anything and everything that I've said about something should be your holy grail in life. I am not trying to establish any more of a cult than I already have. But the idea is that I want to take the best of the best and make sure that any question you may have can be answered by the right people who have done this. And we're going to have a course called 42 Days to Better Breathing. And it's going to be really, really good. And of course, I'm biased, but I work a lot. So you know what? I accept the bias. I can't be everything. Humble is not one thing that I am. I just have to tell you, that's my weak spot. But that is what we talked about cough. We talked about medicine. I'm going to stop and take some questions. It's 7:59. I'm 40%. I'm really only 20% of where I wanted to be by this point, because I really was hoping to get through 5. But you know what? We'll come back. We'll pick it up next month from where we are. I'm going to go to questions now, and I'll answer questions for 30 minutes. Okay, so let me talk. Let me go to some questions. Can you do the yogic forward bend to clear the mucus out? So the answer is maybe yes, maybe no. Okay, so let's talk about a forward bend. Okay, so what does How many people here get short of breath when they tie their shoes or when they lean over? Okay. Think about why that is. Okay. If you think about this like a wallet, right? Here's my wallet. And you notice it's empty. No, I'm kidding. But here's my wallet. Imagine the top half of my wallet or a suitcase. And this is my thoracic cavity. And this is my abdominal cavity, right? And if we think about this like an accordion, this is squeezing the air out, breathing the air in, squeezing the air out, breathing the air in. So when you're leaning forward, okay, and I don't mean forward like this, because fixing the upper extremities, okay, actually will help you breathe. But when you're forward like this or like this, what you're doing is you're preventing air from moving in most effectively. And ideally, what you want to do is you want to be breathing in when the accordion is opening, right? Because if you're trying to breathe in when the accordion is closing, that is what makes you cough, or one of the things that makes you cough, and that is what makes you short of breath. So the answer, can you do a yogic forward bend to clear the mucus out? Definitely. You can do anything you want, okay? And I'm not saying that smugly or glibly. I'm saying try it, okay? I'm saying try it. If you have an idea or you have a sense that something may be helpful to you, try it. And if it works, keep doing it. It's that simple, okay? You know, it's like when you go to the doctor and they say, you know, it hurts when I do that. What do they say? Don't do that. Right? Or say, how do I get to Carnegie Hall? Practice, right? So try different things. If they work for you, who cares what I say? Okay, it doesn't matter what I say. I'm going to give you ideas. I'm going to give you suggestions based on the thousands of patients I've seen over the last 30 years. But if you tell me that what I'm telling you doesn't work and you've tried it, like you can't just tell me it doesn't work, or you can't tell me it's not going to work, right? I hate those people in meetings. You say, hey, why don't we try this? And they say, it's not going to work, right? If you've tried it, if you try what I say and it doesn't work for you, don't do it. I give you full permission to veto anything that we say if it doesn't work for you. Or my new joke is this. Say, listen, you have ultimate veto power. So if you don't want to do something, let us know and we'll call Vito and he'll make you do it. Anyway. So the idea is if it works, do it. Keep repeating it. If you like it, do it again. Okay. It's that simple. Okay. So yogic forward bend, try it if it helps you. But in my experience, what I find is it's not one thing or the other. It's usually a combination of things, trying different positions, trying different techniques, combining them in different ways, right? It's like, again, if you have a bun, a hot dog, and mustard, you're having a hot dog and mustard. I mean, it's that simple. But if you have a whole lot of ingredients, it gives you the opportunity to try different things, okay? How do I know if I have mucus issues if I don't cough? Does it affect shortness of breath? So the answer is mucus can definitely affect shortness of breath, right? Because imagine if you have an air filter and that air filter is clogged with dust, less air is going to be filtered, right? And it's the same thing. If mucus is clogging your airways, then you're going to have more difficulty breathing air in, blowing air out, right? So if you don't cough, how do you know if you have mucus? You can listen to it. So a clinician can listen to it with a stethoscope. You can even learn how to listen with a stethoscope. Or you can try some of these techniques and see if you cough mucus up. Now, some people will cough and cough and cough and no mucus will come up. If you do the techniques, if we bang on you, if we try different things and you don't have mucus, either you don't have a lot of mucus or you have a little mucus and it's coming up through the normal pathways. Ideally, we're not supposed to be aware of mucus all day, right? If we're aware of it, it's telling us that we have some kind of situation. What do I know about NAC, N-acetyl L-cysteine 600 milligrams? So here's what I know. I don't know a lot about it. I don't know why. I have an aversion to learning a lot about it because I hear people talk about it all the time. I've chosen not to make myself a super understander of it. Why? Because I'll tell you, Mark Mangus, who I call respiratory therapist laureate, who was the co-author of my first book with me, loves it. He thinks it's great for helping to clear secretions. He thinks it's great for, thinning out mucus. And if Mark has used it extensively, which I know he has, and thinks it works, that's good enough for me. So I would say, again, I think it's worth a try. I think anything that I say is worth a try. If it involves medication or a new technique, check with your doctor first just to be sure. But I think you give something a try and see how it goes. So here's another question. My medications consist only of antibiotics for NTM and MAC. The rest is clearance procedure. So that's a great question, okay? So the question there is, okay, you're getting antibiotics to treat the actual infections, but the question is, would you clear better if you had some type of wetting device or some type of wetting solution like saline? Would you clear better if you had a bronchodilator to open you up and allow you to move more air? Would you clear better if you had a nebulizer? The answer is maybe. So I would ask my doctor about that. And you know that if you have NTM or MAC or MII or any of these infections where, you get sick over and over and over again, and you're prone to every little bug that walks by, okay, then in my opinion, you want to throw the full arsenal at it, right? It's like if you have cockroaches because you haven't cleaned under your sink, I could tell you a good half hour of my most recent mouse stories, because I have a mouse infestation that would rival the Pied Piper that I'm trying to deal with here. But the idea is that, think of it like dusting your lungs, right? So if you don't dust for a month, guess what? You get more dust, then you get thicker dust, then eventually the dust gets some kind of wet or moist and sticky. And the same thing happens with your airways. So in other words, if you dust a little bit every day, or you vacuum a little bit every day, then things stay clear and you're never dealing with those giant dust bunnies. You're dealing with little bits of dust that are very manageable. So the idea is that if I had a condition like NTM or MAC, where I know that secretions are a problem, where I know that if that mucus stays down there and, sits around in that dark, area, that moist area that's perfect for growing things, well, I'm going to get sick a lot more than if I take on a very serious secretion clearance program. And, look, my goal is not to make your whole life about your respiratory disease. In fact, the opposite. I would say my goal always is to take the spotlight off of illness, okay? But it's not effective for you to not think about your illness for a month and then wind up in the hospital for a month because you got an infection. I'd rather you think about it for 10 minutes a day or 15 minutes a day and then go about your business and stay out of the hospital. Eventually, you lose the time. There's a saying, I don't know it exactly, but it's something to the effect of, if you don't make time for health or prevention now, you'll have no choice but to make time for illness later. So, NTM, MAC, secretion clearance should be a big, big part of your health and wellness program. Do people with PAH typically have secretion problems? The answer is not necessarily. They could, but PAH does not in itself cause or increase secretion problems. I have a severe chronic cough and I seem to cough up more mucus right after taking some meds. So that makes sense, okay? With this coughing, should I be using a tool or something? How do I find out if I need it? My doctor has never told me much about this, so I don't know which lobe it is coming from. Should I ask my pulmonologist? So the answer is definitely ask your pulmonologist, because sometimes somebody can have a condition and we know exactly where that condition is. You can have bronchiectasis in your right middle lobe. You could have bronchiectasis in your right lower lobe. You could have bronchiectasis in your left lower lobe, right? So knowing where it is, if it's in a localized area, is going to be very helpful to you, because if you know that it's in your left lower lobe, then you know that you're going to get the most bang for your buck by lying on your right side. And the average person, like, you're not going to sit here and say, oh, I feel it over here. It's probably in my left middle lobe. But by doing a side-to-side program where you do a few minutes on your left side, then you do some time on your back, then you do some time on your right side, then you do some more time on your back, and you do that as many times as it takes in order to make sure that your airways are really clear, then you should hit all of the lung areas for the most part. I do feel I need to get out what's in my chest Great info. Thank you. And again, we have multiple offerings from the past X number of years about secretion clearance and proper medication use. I use Trelegy in the morning and Spiolto in the night. It seems to work well. Give me 1 second, because Spiolto, in my opinion, is not available here in the US, but Spiolto, let me see what it is. So here's the thing. So Spiolto contains 2 bronchodilators, okay? 2 long-acting bronchodilators. The Trelegy that you take in the morning also contains 2 bronchodilators, 2 long-acting bronchodilators. So in other words, the Trelegy contains 2 medications that are in the exact same class as the Spiolto, plus the corticosteroid, okay? So when we talk about these things, okay, the questions to ask are, number 1, are you, again, I'm not questioning your doctor. I'm sure your doctor, knows what they're doing, but Trelegy is typically once a day. I don't know if Spiolto is typically once a day or let's see how many times a day it is usually. But anyway, the point is, if your medication, if you're taking long-acting bronchodilators that are supposed to be once a day, then taking 2 sets of long-acting bronchodilators may not be exactly what you need, okay? It could be, and there are reasons why you might be doing something that's different outside of the norm, okay? The one that you are talking about with the Trelegy, okay, is the one that has the 2 bronchodilators and the steroid. Now that brings me to another point, okay? And Trelegy is the perfect example of making this point, okay? Why is Trelegy such a great thing? You say, well, this is great. It has all 3 classes of medication in one in one inhalator, right? In one inhaler. Sounds like a great thing, right? But listen to what I said before. What if you're locked up tight, right? What if you only take this one spray, this one puff, and you're locked up tight? Well, it's very possible that you're going to lose the benefit of all 3 of those medications. So initially, there were only short-acting medications. There was albuterol, right? And all the analogs of albuterol. And then there was, ipratropium bromide, which is Atrovent, right? And then there was Combivent, which was a combination of albuterol and Atrovent. And those are short-acting bronchodilators that last 4 to 6 hours, right? Then there were long-acting bronchodilators. And then for some reason, they started combining one of the long-acting bronchodilators with the steroid, okay? And again, to me, that doesn't make any sense. To me, there's benefit in each step of the way. And what I mean by that is, I take a bronchodilator, right? It's like this. I have an appetizer, I have my main course, and I have my dessert, right? There's benefit to each one. The appetizer gets us ready for the main course. The main course satisfies us, and the dessert ties up the meal, right? Now, yeah, sure, we can take them all and put them in a blender, okay? And we can drink it as a smoothie, but that's going to be much less satisfying. And I would make the case that in more cases than not, by taking a medication in combination, you sometimes lose the benefit of the individual medication. So again, my favorite combination, I like combinations that will combine both long-acting bronchodilators. That I'm good with. And the reason why is because we know that anticholinergics and beta-2 agonists work best when taken in close proximity to each other. So don't take your Ceravent in the morning, or don't take your long-acting beta-2 agonist in the morning and your anticholinergic in the evening, right? That's the case I would make. I would make the case for taking something like a Noro, where you get the 2 bronchodilators in one, let them start to work for 15 minutes before taking the steroid. Take the steroid separately. But I would also make the case that, guess what? Maybe it's better to take, the nebulizer with one. The nebulizer is great also because it starts to work with the first breath. So it's almost like digging a hole, right? It's like we're digging. The more we dig, the more breaths you take, the deeper we get, the more effective it is, right? But the idea is that when you take them all at once, my concern is that some people, especially if you have trouble with breath control, especially if you have a hard time using the device, will not get the full benefit of all of the medications that are in there. I have your books, and I'm very grateful for the information, so helpful in understanding. It seems like most of tonight's information is for COPD, but as an IPF patient, I'm not experienced. I really enjoy listening though, because your explanations are so clear. Okay, thank you. Newmark uses radio waves to destroy the nerves that overproduce mucus. Okay, I do know what you're talking about now. I didn't know that it was called the Newmark procedure. But yeah, absolutely. And again, if it works, do it. Okay, if the proof is in the pudding, right? So again, there are some basics here, right? There are some basics, right? If you learn to paint and you're using acrylic, okay, then we know that you want to go with the darks first, and we want to go with the lights later. If we're using oil, we know that we want to go with the lights first and the darks later, right? But an artist is going to take these different things and experiment. A chef is going to take these different things, and instead of cooking for 3 minutes on 400, he may cook for 6 minutes on 6, et cetera, et cetera. So the idea is that we teach you the most effective ways, and we teach you the things that are going to be the most effective for the most people, okay? But again, there's room to maneuver in different ways, and there's always ways to tinker with a program, and that doesn't just include your medications. It includes your exercise program, and it includes nutrition, and it includes stress management and anxiety training, and it includes prevention of infection. So again, start with the basics, and then let's get a little, not fancy with it, but let's experiment to see if maybe there's something better, or maybe, you know, if this is working well, maybe we could get it to work better. Maybe we could go from an A- to an A. Is it normal to have mucus all day? It's normal to have mucus all day. We're producing mucus every second of every day, okay? But it's not normal to have big globs of mucus, to be coughing on mucus, to have an overproduction of mucus, to have an overthickness of mucus. So, you know, the idea is that we're constantly doing a little bit of dusting. We're doing dusting all day, not leaving it until, hey, guess what? Now we have to move the refrigerator and clean up all that milk that we spilled a month ago, and it's going to be really disgusting. My mucus comes from my sinuses. I have emphysema and asthma when I wake up and blow my nose all day, since I'm a nasal breather. So that's a good question or comment. You know, the thing is that some people do have mucus that come down from above, come down from their sinuses, and that's a different issue, right? But that mucus can come down from your sinuses, and then it can go into your esophagus and you can swallow it, or it can go into your airways, or it can come up from above. So it's sometimes tricky when you have a sinus issue and you have a respiratory issue to know, is it coming down from below, above? Is it coming up from below? And I always recommend that anyone with a respiratory condition makes at least one appointment with an ENT. And the reason why I say that is because, you know, there's the idea of the unified airway, which is that air comes in from upper respiratory tract, comes all the way down, okay? And something can go wrong at any point along that way. And if cough is really an issue, there are people who, you know, cough and cough and cough and cough, and it's not related to their respiratory system at all. It's related to their GI system, and it could be reflux. So again, you know, when we hear, you know, wheezing, we think asthma. When we have knee pain, we think arthritis. But in today's society, especially, there's very much knee-jerk reaction medicine. And, you know, I can say over and over again, 95% of what I know, I learned from watching House. No, I'm just kidding. But you can learn a lot from watching House, okay? Because House is the ultimate differential diagnosis. And if you think about it, what differential diagnosis means is that if somebody comes in and has a complaint, you have to list and consider all of the different things that can lead to that complaint. And as you move along, you eliminate and eliminate and eliminate. And then, you know, you're left with one diagnosis, okay? And very few doctors have the time to do that type of differential diagnosis. And a lot of times it's like, well, what's the most likely thing it is? It's wheezing, it's probably asthma, right? Knee jerk. And that's not always going to give you the answer. So if something's supposed to work and it's not working, go further, get a second opinion. And if a doctor says to you, There's nothing more I can do for you. Some people don't like that. I don't like to hear there's nothing more you could do for me, but I say, well, thank you for telling me. Let me find someone who may have something they could do for me, or who's not going to quit, or who's going to try 25 different things. Again, if Thor gets into a fight, he's going to use his hammer. I want somebody who's got multiple tools and a lot of experience. Does the albuterol compete with receptor sites with Trelegy, using it before the Trelegy? In my opinion, yes. In Mark Mangus's opinion, yes. Who do I trust most? Myself. Who do I trust second? Mark Mangus, okay? So, the idea is that if you have short-acting beta-2 agonist, okay, which is your albuterol, and you have long-acting beta-2 agonist, which is in your Trelegy, okay, we believe that if you take the albuterol first, it can compete and take up the beta-2 sites and compete and actually block the long-acting beta-2 agonist. So in other words, you've filled your sites with the short-acting, and people say, well, you know what, this doesn't last for 12 hours, maybe because you blocked all the sites. So it's like, if you're having an event and, you have people who you want to sit in the front, but if, people that you don't know that well come and take all the front seats, then your family has to sit in the back. Prioritize your family. That's what I'm trying to say. Always prioritize long-acting medications over short-acting medications unless you're in trouble. If you're in trouble, if you're in a jam, if it's a code red and you need immediate relief, go with the short-acting rescue medications. Can you say the way you do lay left to clear, vice versa? Otherwise, I will look in the book. Yes. So when you lie on your left side, okay, what we're doing, so look at it like this. So if I lie on this side that's up, okay, this is the side that's draining. So when you lie on your left side, I raise my arm up to open my right lung, deep breaths in and out, deep breaths in and out, using the different devices, okay? And that will help you drain. Once you've cleared that side, do the other side. It's my sinuses. I can use a full box of tissue, take illness meds, and takes forever to get better. Nebulizer is great, but other meds are not working. Okay. That is, there's more to that story, and, I'd love to talk about it sometime. But yourself, and, there's, again, I think there are specialists and there are real specialists. There are specialists and there are specialists, right? I mean, just because somebody is a specialist doesn't mean that they're as good as every other specialist. So to me, I always look for people, I look to work with the best, in everything that I do. I have a lot of, this is a secret, I'm not going to say it loud, but I have a lot of doctors that refer patients to me. I would never refer patients to them, okay? I only refer to people who I think are the top guns. So if I give you a referral, in 30 years, I've only given one referral to somebody that they didn't like. Everybody else has been a perfect thing. I had one person, I sent her to an ENT, coincidentally, we're talking about it. She came back, she had a problem with everything, starting from the waiting room to the people working there, to the doctor who I know for like 20 years, and he's also my own doctor. I know it was this person, but I take referrals very seriously, and I make it my business to know who's the best at what. I'm also very lucky because I'm in private practice and I work with all the hospitals in New York City. So I get to see how everybody practices, which is really interesting. A lot of people don't know this, but like when you work for NYU, you know a lot about how NYU works. You don't necessarily know how Mount Sinai works or how Cornell works. I've been very lucky in that, thankfully, no one has discriminated against me because, we haven't aligned with anybody. That's why we stayed independent when we first opened. But the idea is that, find the best. There's always someone who can give you a second opinion. And if you get a second opinion and it doesn't work, get a third opinion. And if you get a second or third opinion and it's exactly what the first opinion was, it may not be what you want to hear, but at least it's reassuring that you're doing everything right. Oxygen sats are low in sleep, get to 92. I noticed if I exert the next day, it's higher back to normal. So the idea about that is that you may need oxygen at night, and you should have at a minimum an overnight oxygen study. Okay, but I will say this, a lot of people think they know their oxygen saturation when they sleep because they say, as soon as I wake up, I put this on my finger. But just understand that that's not an accurate reading, because by the time you open your eyes, you've already gone through a lot of stages of awakening, so that's not an accurate reading. That's why you need an overnight oxygen study at a minimum, and a sleep study if your overnight oxygen study shows that you do desaturate. What do I know about hyaluronan? Absolutely nothing. I've never heard the word before, so I will look it up. I'm getting some mice advice. Thank you. Does Daliresp reduce mucus production? Reports conflict, and it's very expensive. In theory, it could. In practice, I've seen people who say it reduces mucus production. I've seen people who say there's no change in mucus production. Again, talk to your doctor. If, not all things are for all people, and not all things work exactly as they can. I can't get things moving since COVID and pneumonia. Great question. Okay. As you know, we've seen a lot of long COVID patients. There's got to be, that's such a complex thing that you're saying right now, because pneumonia can knock you back, and pneumonia can certainly set you back. So can COVID, so can long COVID. So that's a very complex conversation, which I'm happy to have, but not in this format. Would somebody be concerned upon exertion getting dizzy, lightheaded, been drinking but no alcohol, and falling when getting up from bed? Yes, I would be concerned if I get dizzy or lightheaded and if I fall when I get up from bed. Absolutely, that needs to be evaluated. I have to get my dinner on the table. Go for it. Does Mark, the breathing specialist you mentioned, is he on any of your webinars that you've done? Yes, he is. Several of them, and they are posted. His name is Mark Mangus. How do you know if you have some lung issues in addition to IPF? See a pulmonologist. Mark Mangus, somebody posted Mark Mangus, look for lecture 5, January 2020. We also have done a bunch in like 2016, 2000, and the material for the most part holds up. Some of the medications have changed, but the material pretty much holds up. Someone said Daliresp is now available in generic. Somebody said I use Symbicort in the morning and evening, followed by Spiriva once daily, ipratropium bromide via nebulizer once daily. Is that the correct sequence? My answer would be no, okay? And the reason why I would say that is because, number one, I would use the Spiriva before the Symbicort, okay? Personally, I'm saying what I would do. I'm not saying what I think you should do, but why would I do it that way? I would do it that way because the Symbicort contains one bronchodilator and the steroid. So I would want to take the second bronchodilator and the steroid after I've taken the first bronchodilator, which is Spiriva, and given it a chance to work for 15 minutes. The other thing is that ipratropium bromide is the short-acting version of what's in Spiriva, okay? So in the same way that somebody asked about albuterol and Symbicort before, or albuterol and Trelegy before, the ipratropium bromide should not be used before the Spiriva because it can compete for binding sites. And it can be very thick. I don't know what that is referring to. Thank you. Not bedside manner. LOL. I don't know what that means. Thank you. You're welcome. How can I get a plan going? I do have so much energy that I'm exerting self. I have sleep problems. I've been waiting for you for 2 years, Lily. Call the office, set up an appointment. I've been waiting for you. Always a pleasure. Glad you're okay. Thank you. Have a great day. Maybe balloon sinuplasty for that person. Maybe. I would not comment on that personally. Docs don't care about oxygen. I was in the ER, nurse at 92 SATs, but no biggie with all doctors. Thanks, we'll look into it. How can you get a copy of this seminar? Will be posted at some point. It's hyaluronic acid for inhalation therapy. Thank you for that. Again, I don't know enough about it to comment on it. Which hospital in New York City has the best respiratory therapy program? I don't know a lot of respiratory therapists in New York City, believe it or not. I just don't. I think we utilize them here in New York a little bit differently than they do in other parts of the country. But even when I worked in the hospital, I didn't have a lot of experience with respiratory therapists. And the majority of RTs that I know from, other parts of the country. which has the best respiratory, the best pulmonary doctors. I could tell you this, every single hospital in New York City has outstanding doctors. You just have to know who they are. I know brilliant pulmonologists at every single hospital in this city. And I know quacks at every hospital in this city. So you have to know who they are. And it's not always the New York Magazine best doctors. Okay, those are very political and often paid. Not a question, just appreciation. I live in Massachusetts. Have bronchiectasis caused by cancer medication. Learned about you through a UCSF Better Breathers group. Almost done with boot camp. That program helped me focus my exercise better on my respiratory needs. Dedication is inspiring. Thank you. What I've learned from boot camp has made such a difference. Husband has noticed the changes and gives you a lot of credit. Credit's great. I want money. Okay, send the money to the Pulmonary Wellness Foundation. The credit is great. It doesn't help us do more programs. www.pulmonarywellness.org. Sounds like a joke? Not a joke. I hate asking for money. The other foundations, associations, shameless. They have no qualms asking for it. Trust me, it's in every email. I don't like it, but when it comes up like this, I have to tell you, credit don't work here. Thank you, though. Remember to stay hydrated. Where can you get a jacket like mine? You'd have to make it. You have donated. Thank you. That's the end of the questions at exactly 8:30. Have a good month, everybody. I will see you next month. Announcement coming soon. New 42 days to better breathing coming soon. It will cost money, $99. Start saving now. Have a great month, everybody. Great to see you. Thank you for your time. And now the dogs are like, when are we going out?
Thank you.
Very welcome.
Thank you,
It's a pleasure.
Noah.
My
Thank you.
pleasure. Eva, I
Thank
recognize
you.
your voice. Hello.
Thank
Noah.
you.
Thank you
Thank
so
you, Noah.
much. Thank you
Noah,
as
I like
always.
too.
You're
Thank
very
you,
welcome.
Noah.
Yes, I do talk about fibrosis. Next time I'm going to start with exercise and nutrition, and we're going to hit a lot of pulmonary fibrosis. So
Thank you.
this was this, but we're going to talk a lot about pulmonary fibrosis as well. I see a lot of PF patients, and I actually, coincidentally, me and a group of patients just wrote a new book about pulmonary fibrosis. And it's
Noah, I
pretty
like
good.
to, I like
Fabulous.
to take something to you.
What's that?
I have something
What do you
for
mean?
you.
All right, come to the new place.
Yeah, I like to take it in person, you know.
Bring it. We got a new spot.
Okay.
All
I'd
right.
have to come by Amtrak from DC, but I'll do it.
All right, deal.
Be
All right,
well.
we've had people come from as far as Afghanistan.
I'm not surprised.
So we've had people come. Luckily, we have a hotel on our block now. We have a new spot, and there's a hotel right on the block, which is very convenient. So anyway, the dogs are starting to get, there's Monkey. Where's Chew? Where's Chewy? Here he is. The dogs need to go out. Have a great month, everybody. See you in February. Bye-bye.
Take care.
Thank you. Thank you.
Be well, everyone.
Bye-bye.